I'm Jonathan Rikoon. I was asked to moderate the session because I'm a lawyer and I've done some work in the legal framework around healthcare decisions for persons who lack capacity, and so I'll try to talk about that a little bit. The other speakers are as follows. Dr. Beth Popp, who's going to speak first, is the director of the Palliative Care program at Maimonides and associate program director for Hematology-Oncology, a graduate of Washington University in St. Louis, and she did a fellowship in cancer pain management and palliative care at Memorial Sloan. There's a long list of why she's such an expert, trust me. Rabbi Dr. Aaron Glatt is associate rabbi at Anshe Chesed and assistant to the rabbi at Young Israel of Woodmere. He gives a daf yomi shir for quite a while. He's also an international lecturer on medical and halachic issues and has offered svarim in the area. He has been executive vice president and chief administrative officer at Mercy Medical Center in Rockville Center, and prior to that, president and CEO of St. Joseph Hospital. Board certified in internal medicine and infectious diseases. He was a full professor of clinical medicine and former associate dean at New York Medical College. So the structure here is that Dr. Popp will start by talking about some of the medical issues. I will talk about the legal framework, and then Dr. Glatt will talk about some of the halachic issues. If you have questions, it's actually a pretty small group, so I don't think we'll have too much trouble, but the protocol is to please write down the questions and bring them up, or as the case may be, bring them down. Dr. Popp?
Good evening. I usually speak to primarily medical audiences, and my children asked me what I was going to talk about tonight, and I said, well, I was going to kind of give a medical Dvar Torah, and they weren't quite sure what that meant, so let's see. In this week's Parsha, Parshas Vayechi, we're told that someone comes to Yosef and says, behold, your father's ill. Hinei avicha chola. Yaakov is ill, and he's weak, and he's confined to his bed. Yosef brings his sons to his father's bed, and Yaakov exerts himself and sits up in the bed and speaks to his family. A social worker in our day and age would say he engaged in a life review. He took stock of the events of his life, and he blessed his grandsons with a blessing that's very familiar to all of us from putting our children to bed. Yaakov acknowledges aloud that he is about to die. Vayomer Yisrael al Yosef, Hinei anochi mes. He asks all his sons to come, and he blesses them. He tells them how and where he wants to be buried, and he instructs his children to make sure they carry out these wishes. At the end of the Parsha, Yosef too foresees his death. He repeats the words that we heard earlier from Yaakov, V'yomer Yosef al achiv anochi mes. And he assures them that Hashem will remember them and bring them up out of Mitzrayim to the land that was promised to Abraham, Yitzchak, and Yaakov. And he asks them to bring his remains to a proper burial out of Mitzrayim. In the Parsha, Yaakov isn't in a hospital, and he's not surrounded by medical equipment and physicians and nurses and respiratory therapists. He's able to speak and to bless his family. His children don't face agonizing decisions over whether or not to do emergency surgery or put in a feeding tube or use a ventilator. And that's what my patient Chani wanted for herself. She wanted to be at home, to have her family around her, and not to have them tortured by difficult decisions. But today, parents and grandparents almost inevitably face at least one hospitalization, and many spend a great deal of their final days, weeks, or months in the hospital. We have been zocha to see the bracha of medical advances that have allowed many to survive illnesses and accidents that only in the recent past were rapidly fatal. But these developments bring with them technology and treatments that can be a double-edged sword. The degree of wisdom that's needed to navigate these many decisions that need to be made is astounding. And it results in the need to work within a healthcare system, like all human inventions, that is far from perfect. When Chani came to me, she told me The clock is ticking. She had metastatic breast cancer and had developed some serious complications of her treatment. She said, "I always knew it was ticking from the time I first got diagnosed, but now I realize it's ticking a little bit faster." As a hospital-based physician who takes care of seriously ill patients, I see families and patients struggle all the time with situations in which they find themselves. It is enormously stressful. Someone they love is very ill. Someone they love may be at the end of their lives. They don't often know whether this is the time for ushmarta ma'od al nafshosechem, when they should be fighting with all their effort for a recovery, or simply more time in the state that the illness has left the patient? Or is this the time that Hashem has decided that the neshama of this precious person should be returned to him? The families are not Nevi'im, and neither are we, the doctors and nurses who are taking care of them. These loving families want to do the right thing, but what exactly is the right thing? Chani had been told that her liver had been seriously damaged by the treatment she had gotten, and it meant that she wouldn't be able to get pain medicine. She laid awake at night worrying whether her cancer would cause her severe pain and she wouldn't be able to be treated before her liver completely failed. That was what her nights were like, tortured with worry. But her days? She went to support groups and she went to chumash parties. She went to doctor's appointments and she went to chasanas. Many people would have described Chani as dying, but Chani was busy living. As a palliative care physician, I'm often called as a consultant to assist in the care of patients like Chani. And while Chani sought me out for a referral, many patients are referred to me and they are worried and anxious. They're not sure what to make of the suggestion that they come to a palliative care doctor. There's already a great deal of anxiety with their situation, and the recommendation that a new physician get involved, like any change, can bring with it more anxiety. Add to that the fact that there are so many misperceptions about palliative care, and the anxiety level goes off the roof. So first, let me take a minute to say exactly what palliative care is, and clarify for you when and how it can be helpful. Palliative care is care that is provided by an interdisciplinary team, a group that consists of doctors, nurses, social workers, and chaplains at a minimum, and is provided in conjunction with treatments for the underlying disease, which is usually something that's progressive or maybe potentially life-threatening. It is designed to minimize the difficulties that living with such an illness brings. Whether or not the illness can be cured or slowed, whether or not the patient can be restored to a previous level of health or function, or will at best remain the way they are. Palliative care is designed and works to address physical symptoms like pain and shortness of breath, nausea or confusion, among others. It addresses psychological symptoms like anxiety and depression. It addresses caregivers who are overwhelmed with the responsibilities and decisions that they face and are struggling with their own emotions as they face the possibility of loss, whether that possibility is realized or averted. It addresses the family who's struggling with simply seeing somebody who they love seriously ill. We know the healthcare system, and we get to know the patient and their family, and we work with them to help them figure out how they can best use the resources of the healthcare system to meet their needs as they face the challenge of this serious illness. Good palliative care may not require a specialist, and many primary care physicians and specialists in fields like geriatrics and oncology or neurology provide the medical components of palliative care, and they work together with hospital or clinic social workers and nurses to create an ad hoc palliative care team. It's hard to find a situation of serious illness where this kind of care isn't of benefit, once one realizes what it is. While much palliative care is that's provided by specialists who are fellowship trained like myself is for patients who are thought to be closer to the end of their lives, that is because these are the patients who have the most complex and intensive needs. One other misconception that I want to address very clearly is the notion of time. The purpose of palliative care is not to shorten or alter the time course of the underlying disease. Most palliative care physicians see good palliative care as a means to prevent people from feeling desperate enough to think about things like physician-assisted suicide. And while I hate to mention legal issues with a lawyer at the table, I will point out simply that the legal right to palliative care was explicitly mentioned in the Supreme Court case in 1997, Vacco versus Quill, which was a case that came out of New York State and upheld New York's right to ban physician-assisted suicide, and is codified in the New York State public health law. Going back to the Parsha, it's interesting to note that not once, but twice, where we have Parshiot that address the deaths of our matriarchs and patriarchs, the Parshiot are not known as Sarah's death or Yaakov died, but Chaye Sarah and Vayechi. One of the lessons we take from this is expounded upon by Rashi. We accept that, at least for now, we're all mortals, and at the time Hashem decides, our earthly existences will end. That's the way Hashem made the world. But until that moment, our job is to live our lives fully, realizing the purposes for which He put us in this world. Palliative care endeavors to remove obstacles to that by alleviating symptoms and providing support, by minimizing to the degree possible the challenges of living with an illness which accompanies us for this period of time in our lives. And that was my patient Chani. She never lamented her situation, though it made her sad sometimes to think of what she might miss. She had tremendous emunah, and she accepted that her illness and the treatments, both the good and the bad that came from them, all came from Hashem. Chazal tell us, Ezahu chacham, haroa et hanolad. Who is wise? The one who sees the future. Well, you're all chachamim because you came tonight to learn about what you can expect in the future and how you can help yourselves, your parents, your friends, and your neighbors should they find themselves coping with a serious illness. One of the important ways which you can do this is to learn how to ask a medical shaila. There are many illnesses that people find themselves, bring them to the point of having a serious illness in a hospital setting. There are many issues that come up. But one thing is in common for all of them, from patients and families, is the need to ask shailas about these. The situations are complex, the details matter, and the stakes are high. For people who have lived their lives committed to being Shomrei Mitzvot, making sure they get care that is not in violation of any of the Asurim is important to their peace of mind in these stressful situations. Being afraid to ask is common. People feel overwhelmed by the responsibility of giving over the information that the Rav needs to paskin the shaila. They fear that they may be judged negatively for asking about limiting treatments or putting a parent in a nursing facility. They feel caught between the needs of parents or spouses and children. They've been told that some treatments might be too burdensome or ineffective. And they fear getting a response that they will have to agree to a treatment that their parent told them they didn't want. They know there's a halachic issue, but they can often be afraid to ask a shaila. They think maybe the answer's obvious and they shouldn't need to ask. But maybe they do. And they can't act because they fear that the assumption they're making might actually be the wrong assumption, and what they are contemplating doing is against halacha. You and your loved ones can avoid this by deciding before there's a crisis who you want to ask shailas to. Often there's a large family, and there'll be many relationships with many rabbanim. And a consensus needs to be reached about who will be the one to whom they ask the shailas. Often there are many relationships with many rabbanim, but none of them are comfortable answering these kinds of shailas. But they can help be a conduit and make a relationship with a Rav who is comfortable paskening these shailas. And it will be someone who has a hashkafa that's appropriate for the family and knows the medical issues and has the expertise halachically to answer these complicated questions. Once you've identified the Rav, you need to know what your threshold is for asking shailas. Just like people vary in their threshold to ask a shaila about Hilchos Shabbos or Kashrus or Taras HaMishpacha, people vary in their thresholds to ask questions about medical care. And it's important to have a sense of when you're going to ask shailas for what kinds of issues. And it's important, I think, to keep the Rav apprised of what's going on. Then when there's a crisis, there won't be a need to provide an enormous amount of background information, but rather to recap the events and fill in what's happened since the last conversation. Finally, it's vitally important to make sure that the Rav has clear and accurate information about the patient's medical condition. Ask the doctor to explain the medical situation to the Rav. Ask the Rav to speak to the doctor. I can't imagine the pressure that Rabbanim feel having to paskin these very high-stakes life or death shilas when a son-in-law comes with information that his wife told him that the sister said when she spoke to the doctor. Often critical details are missing or information can inadvertently be misrelayed. And again, the stakes are high. No one wants to get this wrong. And if the answer isn't what people hoped for, then there can be an enormous amount of ambivalence about whether the right information was conveyed and how, who said what. And all of this can be prevented if the family and the doctor and the Rav are together on a conference call. It can take a little time to arrange it, but our loved ones deserve nothing more than the best quality decisions being made for them at these high stakes time, just like we go and make sure that they have the best quality care in every other way. Mr. Rikoon is going to talk to you about some other ways in which you can be haroa es hanolad and use legal instruments to protect your rights and ensure you get care that's appropriate for you, for your goals and your values. Before I finish and turn the floor over to him, I just want to tell you a little bit about the end of Chani's story. She fell last winter and broke her arm and had a series of events in and out of the hospital and by her own choice going to rehab while she recovered from her fracture. Eventually, she did develop liver failure, and she came into the hospital. Her family wondered whether they should keep their promise to her to make sure she was cared for at home, but they worried whether or not they could actually give her the care that she needed in the home setting. They worried about kibud aim in this case, but also they worried about their father and how he was coping with the situation. Eventually, they made their decision after asking their shilas in the way in which I've described. And while Chani died with her family around her in her bedside, and she wasn't able to speak and give brachas the way we saw in the parsha that Yaakov gave to his children, she really did give them a tremendous bracha, because she gave them the ability to look back on her life and her illness with tremendous peace of mind and not with guilt, because they knew that they had handled everything in the way that was the best possible way for her. And they were able to spend their time and their memories focusing on the good parts of her life and not focusing on guilt about whether they had handled these things in a way that really didn't do justice to her and who she was and the way she had lived her life. So I will close with that story and turn the floor over to Mr. Rikoon, and I thank you for your attention.
Thank you, Dr. Popp. Lawyers and doctors don't always look at things the same way. And what we just heard is a wonderful example of that, because in practice, I think it's absolutely true that it's the family for an incapacitated patient. That's not the way the law looks at it. So let me tell you what the legal structure is. It's actually an area that's very highly regulated. It's complex. There are different jurisdictions with different rules. There are different sources of law. Sometimes in practice, I suspect they are viewed as guidance rather than binding. I don't think the courts look at it that way, but I think the families and the patients and the doctors sometimes do view it that way. But nevertheless, it's worth taking a look at it so that we can take whatever steps we can to put ourselves in the best posture so that there aren't unnecessary conflicts, so that there aren't treatment decisions that are inconsistent with halacha or with our wishes. I'm going to be talking about medical decision making for incapacitated patients generally. Some of this applies only in a hospital or facility, but some of it is sort of the same rule no matter what the setting. And it's an area where we started, at least I started, coming across this when I was in college in 1976 with the Karen Ann Quinlan case coming out of the New Jersey Supreme Court, which is one of the reasons I decided to leave pre-med and go into pre-law, because I realized what I was really interested in and what I was really not very good at, and they were different. So there was Karen Ann Quinlan. There were several cases coming out of New York's highest court. the Storer case in 81, just 5 years later. A few years after that, the Brother O'Connor case. And then the U.S. Supreme Court got into the act. In the Cruzan case in 1990, the Supreme Court found a federal constitutional right for a patient to make decisions about his or her own care, including refusing care. And that was a landmark case. Probably the most famous case in recent memory is Bush versus Schiavo, the Bush being George W. Bush, who had the Justice Department, the federal Justice Department, asked the Supreme Court to intervene in a Florida Supreme Court case dealing with the dispute about who would decide about medical care for Terry Schiavo. And that became a whole political issue as well. So we've got federal law, we've got state law, there's federal legislation, which is I think called the Patient Self-Determination Act, which requires on admission advising patients about the right to make decisions for themselves. We've got state legislation, which is really what I'm going to talk about. And of course all of that is overlaid with halacha, which deals, I think, more with the substance of the decision. Most of the state and federal law deal with the procedure and the process. So I'm going to try to give you the framework for the procedure and the process. And the first rule is that if the patient is competent, the decisions about medical care are exclusively the patient's. And that's fine in theory, except how often is there a fine line between a fully competent patient who's calm and collected and rational and able to make a reasoned decision based on all the evidence, and sort of the continuum of panic, lack of full information, well-meaning caregivers who perhaps aren't fully disclosing the details to the patient and so forth. So that's something to worry about. But the paradigm is a competent patient makes his or her own decision, and that's it. And that decision in law can include refusing treatment. It can include refusing nutrition and hydration in ways that I'm sure are not entirely consistent with halacha. And so there, obviously, shilas are required as well. Among the ways that those decisions are manifested are medical orders such as a do not resuscitate or DNR order in the right circumstance, or a MOLST, which is a medical order for life-sustaining treatment, a relatively new approach under which a physician decides or issues orders for end-of-life care based on the hierarchy of decision-making that we're going to talk about. Now, what happens if the patient is not competent, and it's reasonably clear that the patient is not competent? Well, here, New York law sets up a hierarchy. The first choice for making a decision is an agent selected by the patient. The document that names the agent is called a proxy. It's a little confusing. You may think the person is the proxy, but the document is the proxy, the person is the agent. That's the language. If you use the wrong language, it probably doesn't matter very much. But the critical point is there can only be one agent, not the family. There's no such thing as a family worth of healthcare agents. And that happens to be true in almost every state, because I recently had occasion to review that. And I think the philosophy is that the medical care provider is entitled to listen to one voice and shouldn't have to try to come up with a pshora among a group of family members who may not see eye to eye. And from one perspective, that's a good thing. It also means that the individual who is going to become a patient, who may be a patient already, has the ability to select who will speak for him or her once his or her lips are silenced. You can also name a successor or a series of successors, and that's certainly the preferred method to avoid dispute. Obviously, you should talk to the agent, make sure you are in sync on philosophy, on approach, on availability, and so forth. If there is no agent named in a healthcare proxy, the law looks to a more cumbersome procedure known as a guardian. And guardians, there's a whole chapter of the law dealing with guardians. Guardians can deal with financial issues, but guardians can also deal with personal issues and healthcare issues, and that's the next resource. To get a guardian appointed is a long, drawn-out court process. You really don't want to have to do that. Okay, but that is the next choice of hierarchy. If there's no guardian and there's no agent, then there's a relatively new statute, about 4 or 5 years old in New York, which sets up what is known as a surrogate. And the surrogate is an individual with a certain degree of relationship identified in the statute authorized to speak for the patient. This law doesn't really say how you pick the surrogate if there's more than one person in that degree of relationship. A spouse, well, most people only have one spouse. Siblings, children, grandchildren, then somebody has to decide. There's been speculation that the healthcare provider can decide. I don't think any healthcare provider really wants to be in that position, but that means if there's no consensus within that class of permitted surrogates, you're going to traipse into court. Again, nobody wants to do that, so do the proxy, name an agent. Now, in the absence of all of the above, if there are clearly expressed wishes, you don't actually need someone to articulate those on behalf of the patient. If there is a medical directive, sometimes known as a living will, although that has a slightly different connotation, and it clearly covers the current circumstances and describes the patient's desires in that context, and if there's no evidence that the patient changed his or her mind, which is a whole separate issue, then the medical provider doesn't need anything else. The medical provider is supposed to follow the living will or the medical directive. The fail-safe, if all else is not available, is the best interests, which is the old rule that nobody really knows how to apply because it's very subjective and leads to a lot of the court cases, a lot of litigation that we were faced with. Now, the agent or the surrogate are required, whichever it is, to consult with the physicians. They are entitled under HIPAA, the Health Insurance Portability and Patient Accountability Act or something like that, to, did I get that right? Close? Close enough. To medical information which is otherwise confidential. So that where there is a person making decisions for a patient, that person stands in the shoes of the patient and is entitled to the relevant medical information. Obviously, if they are not in the medical field themselves, they will need explanations and some hand-holding, but at least they can get that information. The standard in the statute is once again that the agent or the surrogate must act in accordance with the patient's wishes, and the statute specifically says in the state of New York, including the religious and moral beliefs of the patient. And that's partly the result of lobbying by Agudath Israel and other organizations. And then we get to best interests as the fallback. As I mentioned, artificial nutrition and hydration are treated differently. Our decisions regarding artificial nutrition and hydration can only be made based on a reasonable knowledge of the patient's actual wishes. The best interests doctrine doesn't apply. And the theory, and there are actually cases about this, and the theory seems to be that nutrition and hydration is a right somehow different morally, philosophically, than the right to medication. All healthy people intake nutrition and hydration, and to stop it is regarded as, at least by the legislature, as morally more serious than stopping medication. Now, what kind of conflicts can arise? What kind of issues do people face? Well, of course, you simply may not have an agent or a proxy or a surrogate named or available. You may have an agent or a surrogate acting, but not in accordance with the patient's wishes, rather in accordance with the agent's own wishes. Or you may have an agent or a surrogate who's not acting in accordance with halacha and not even asking the shaila, which is critical, and other family members don't like that because they think that there should be a consultation with a rav, or they may even know what the answer is. They may have asked the shaila, and they know that the agent or the surrogate is not acting correctly. You may simply have disputes among family members, and that's where the one agent rule is supposed to solve the problem, but disputes continue to exist. Another case, which actually turns up fairly often, it turns out, is where a hospital believes that a patient has reached the end of his or her life. They wish to rely upon a criterion of brain death. They want to order a brain death test, and depending on how that test turns out, turn off life support. That presents huge halachic issues, and there's actually there are a series of emergency court applications resulting from that. And the other thing to bear in mind is that there are, unfortunately, sometimes financial incentives which act opposite to halachic requirements, financial incentives to terminate treatment, either on the part of the insurance company, the institution, the family. Somebody's looking for an inheritance. It happens, and these are among the issues that have to be borne in mind. So, what should one do? Well, the first thing, as Dr. Popp mentioned, is aseh lecha rav. You need a rav available who is familiar with medical issues, is comfortable with poskening medical shilas, and who knows the medical situation in advance, who does not get a 3 a.m. call with a 50-page chart. It's just not going to work that way. So you need to establish that relationship. You also need a primary care physician and a physician with primary responsibility for the particular serious ailment, whether it's an oncologist or some other specialist, who is sympathetic and prepared to cooperate with the posek. Does not necessarily have to be a frum person, but has to be someone who understands that for this patient, the decisions will be made in consultation with a posek and das Torah. And it may not be so simple to find such a person, but if you don't, it's going to be that much harder. Those are very nice in the abstract and obviously will vary case by case. There's actually something that everybody can do, and that is to sign what we call a halachic medical directive. It is a combination healthcare proxy and medical directive. The original form was developed for Agudath Israel of America, by me actually, and it's now been promulgated. The RCA has adopted it, several other organizations have adopted it, and there are copies of them, first of all, on the folder in the corner there, but in addition, there's a table out front from the National Association of Chevra Kadishas, who have, and at that table they have the halachic medical directive, the instructions, and a little emergency card, which you can carry in your wallet, which simply says, I have a halachic medical directive. Please consult it. Please provide care. Please don't autopsy. Don't do anything. Alert. Very, very useful documents, and not really that hard to sign out and to sign up, to fill out. Everybody should do that, and they're really fairly straightforward. They are state-specific. This is an area where state law varies substantially. There are 30 or 40 states for which the form has already been promulgated. If you have a state other than New York, you can just call the Aguda, 212-979-9000, ask them for the form for your state. Essentially what the form does, and I'll finish with this because time is running, is four things. Number one, it appoints an agent, a trusted person, often a family member, who actually is technically the healthcare agent, who will be empowered to make decisions if the patient loses capacity. And of course, you can name and should name an alternate, only one at a time. There is a declaration that the patient is an Orthodox Jew and wishes his or her healthcare decisions to be made in accordance with Orthodox Jewish law. That is the statement of intent as far as secular law is concerned. Basically, you've incorporated into the New York legal system a reference to say, go find out what halacha says, and that becomes my standard of care. And we think that works. But it's dangerous if you just leave it at that, because who's going to decide that? A doctor who may not even be Jewish? The next critical part of the form is to name a Rav and a backup Rav. And that's where you have to think in advance and do your consultation and your homework. And it basically says, I'm asking my agent to consult with Rabbi so-and-so on these issues. And if Rabbi so-and-so isn't available, then the next one in line. And finally, there's some mechanical material in there which ensures that the agent will have access to the HIPAA protected information. Now, technically speaking, the rabbi is not supposed to have direct access to that because you can only have one healthcare agent at a time. The rabbi really shouldn't be the healthcare agent for a number of reasons. That's usually not a problem. There may be instances where the agent has to be the conduit and interface between the physicians and the Rav, but certainly if you can have the Rav and the physicians speak directly, that is very helpful. The last thing I should mention, because I forgot, is that at that table outside, in addition to the Halakha Living Will material, there is something called the U.S. Living Will Registry, and this is an online data bank which keeps track of who has living wills out there, so that if somebody with nothing other than bare identification is admitted to a hospital, unconscious, no family member, nobody else, at least in theory, the facility can immediately find out whether or not that person has a living will, or in this case, a halachic medical directive. And that's what I have to say, and I will ask Rabbi Dr. Popp.
So good evening, everybody. I certainly agree with everything that my esteemed colleagues, both from the legal and medical profession, have said, so I won't try to repeat what they've so very eloquently stated, but I'll try to point out a couple of additional caveats and halachic points that I think are critically relevant. So we started off with the Dvar Torah, so we certainly want to end on the Dvar Torah as well. And continuing what Dr. Popp mentioned, Yaakov Avinu was the first person to ask for choli in the world. We know that Avram Avinu was the first person to ask for zikna, to ask for old age, and Yaakov asked for sickness to come into the world. And on both accounts, it says HaKadosh Baruch Hu agreed. In other words, being old and being sick are viewed by HaKadosh Baruch Hu as being positive things. In the olden times, young people looked like old people. You couldn't differentiate between them, and people would die by sneezing. The Gemara tells us, Chazal tell us Medrashim on this, that's where the custom of saying Gesundheit comes from. Almost every culture has a God bless you, salud, or something like that, because originally people would die suddenly without having the chance to put their affairs in order, without having a chance to say goodbye to their families, without having a chance to put their financial matters into closure, without having a chance to do vidui, without having a chance to go and say to somebody, I'm sorry if I hurt you, or to have somebody come to them and say, I'm sorry, or to give other messages to the mishpacha. So therefore, HaKadosh Baruch Hu considered it as a very positive thing, as difficult as that may sound to us, for a person to get older, and for a person to get infirm, and then for a person to die. And if we do this with the proper hachanos, if we do this with the proper preparations, many of which have been outlined, then we have a better chance to, quote, die with dignity. The description of death with dignity in the secular world is not necessarily in accord with what halacha states as death with dignity. In halacha, death with dignity means a person who passes away following what HaKadosh Baruch Hu wants for them to do. As opposed to in the secular world, death with dignity means following what that person wanted to be done. Now the two don't have to be different. A person's wishes can be absolutely in accord with halacha. Sometimes yes, sometimes no. And that's why it's so critical, as you've heard mentioned, aseh l'chorav. And I would add my own caveat to Pirkei Avos, aseh l'chorofe nemon. And then the two have to work together, as been mentioned as well. A person has to have a relationship with the physician that will allow the physician to want to and willingly consult with the Rav, to consult on all matters that the patient thinks are important to consult with the Rav. I cannot tell you how many times I personally have been consulted by either Rabbanim, by physicians, or by patients, and have gotten a 100% inaccurate medical or halachic response based upon misinformation. And patients will often ask me shilas in shul about, can I take this medication on Shabbos? Or what do we do in this situation of a life and death situation? And I'm amazed at the inaccuracy of the information that is provided by a layperson. Now, we don't expect laypersons who haven't gone to many years of medical school and residency training to understand what the medical issues are. But therefore, don't expect the Rav to be able to paskin based upon the misinformation that's provided by a family member. The only way that you can possibly have an accurate psak halacha is if the Rav is speaking with either the physician or the family member who's a physician or at least a healthcare practitioner capable of relaying accurate information. Many times in shul, I'm literally asked the question, can I take this medicine on Shabbos? And my medical hat goes on and says, I don't think that medication is indicated, therefore I wouldn't recommend that you take it on Tuesday rather than on Shabbos. And frequently a Rav will tell me the situation. I'll get a call from a Rav, sometimes a posek of renown. And they'll ask me some medical questions about the Psak Halacha. And when I explain to them, they say, now I will paskin 100% the other direction. This is not a rare occurrence. This is Ma'asim B'chol Yom. It is crucial. If we wish to get the halacha right, you can't go and look in Shulchan Aruch for answers that aren't found in Shulchan Aruch alone. Everything is found hafolch ba v'hafolch ba v'kula ba, but you need to know the circumstances. I remember my Rav Shechter Shlita telling us that once the Rav Zatzal, Rav Yoshe Ber Soloveitchik, was asked the question, can you use a watch on Shabbos? So the Rav said, please bring me a screwdriver. And the Rav took the watch apart with a screwdriver. I'm not sure the Talmud was happy about that. And then the Rav paskined, yes or no, whatever it was, you can or cannot use that watch on Shabbos. Because it doesn't state anywhere in Shulchan Aruch that you're allowed to use a feeding tube or not allowed to use a feeding tube. It doesn't state in Shulchan Aruch that you have to put a respirator on somebody or not put a respirator on somebody. It tells us the parameters of Pikuach Nefashos. It tells us the halachos of refuah on Shabbos. It tells us the halachos of end of life. But it doesn't tell us the medical details. And unless the Rav knows accurately what the medical details are, you could be a Rotzeach Rachmana Litzlan B'Shogeg, or you could be somebody who's a chovel, somebody who's a damager to somebody. Again, b'shogeg, the best intention, the greatest people, physicians and rabbanim, can make terrible mistakes if they're not aligned in halacha. So a couple of points I want to go over in terms of some of the difficult halachic issues. When you're dealing with a hospital, so the hospitals, with essentially no exceptions, will follow the path of least resistance. The last thing they want to do is have problems, both from a patient complaint point of view, from a complicated medical, ethical discussion point of view, from a utilization of resources point of view, and from a physician and nurse discomfort point of view. We had a patient in our hospital who was halachically not dead, albeit by New York state law, they were dead. And this is the brain death controversy that was alluded to. And New York state law allows for the religious beliefs of the person to bypass essentially what New York state law would say that the person should be buried. This caused a tremendous amount of anxiety in the nursing staff and in the medical staff. But Baruch Hashem, those fears and anxieties could be allayed by explaining to them. Now again, there are major poskim that say that brain death is halachic death. I'm not here to be the final postek. I'm incompetent to do that. The great Gedolei poskim on both sides of the equation. Aseh l'charav means that the family should follow the Rav that's been designated to paskin for that family. The person who is ill should be making that decision before they get to the point of no return with the healthcare proxy that they designate. This person, the ill person, says, I've lived my entire life with this hashkafa, with this Rav. I want that Rav to paskin for me. It's inappropriate for a child, either more to the right or more to the left, whatever that means, with a certain hashkafa that's different than the parent, to ask their Rav those shaylas. The person lived his entire life following a certain hashkafa, a kosher hashkafa, a proper hashkafa, of many halachically acceptable hashkafos. So it's critical that that patient's wishes in life be honored in death as well. So I'm not here to paskin a shaila, how do you go about deciding brain death? How do you go about deciding should you or should you not put in a feeding tube? There are many different opinions in many different areas of halacha. There's no lack of disparity in opinions when it comes to end-of-life issues as well. And you have great Gedolei HaPoskim on both sides of the fence in almost all of these situations. And one shouldn't say, well, so-and-so had a feeding tube stopped, or so-and-so had a feeding tube inserted. That's the halacha. And Rabbanim can sometimes, again, through lack of familiarity with the very complex medical issues, make statements that Lanias Dati are just not correct. I've had patients tell me, my Rav said to do everything, which many people think is the halachic correct approach, which is absolutely incorrect. You don't have to do everything. You don't crack a chest open of a patient who coded because you can. You do it because it's medically indicated. In 99.99% of the times, it's not appropriate to open up the chest and do open heart massage on a patient that just coded. But if you do everything for the patient, so that would be included in that, which is of course silly. I had another Rav tell a patient, again, Erlich a Rav, Erlich a family, say, no, you're not allowed to sign a DNR. Again, Leni Yazdati, that's absolutely incorrect. You of course are allowed to sign a DNR. Under the appropriate circumstances, with the appropriate halachic guidance, a DNR can be very appropriate. If a patient is racked with pain, if a patient essentially has no expectation, I'm not talking about a small expectation, but no expectation of being able to survive the code, so then there's no reason to code that person. Every person doesn't have to die with broken ribs. Every person doesn't have to die in an ICU setting. Some do. When you don't know, my advice is always, when the medical picture is unclear, then the halachic idea of doing everything usually trumps everything. I get many calls from patients, Nebuch, they were previously healthy and are suddenly brought in an acute state of illness. They'll have a major neurological event. They'll have what looks like a massive stroke. Well, massive strokes can be sometimes absolutely reversible, and sometimes they can unfortunately not be reversible. How do we know? Well, guess what? We don't know. We frequently are incapable of giving an excellent prognosis or a poor prognosis accurately in the first 12, 24 hours. And I have seen patients who had very poor prognoses walk out of the hospital alive and well. One of the best stories I have is in the ICU, they were writing off this elderly Rav. This Rav has been a Rav for 50, 60 years in many different communities. And he has a chronic trach, which means that he has numerous lung problems. He was in the hospital with a very serious lung infection and numerous other complications, and everybody was certain that he would not survive. And Baruch Hashem, he did, because the doctors make mistakes. And he survived, and I had the pleasure of announcing him to my tzibur when I was learning between Mincha and Marv, and I said, I'd like everybody to welcome Rabbi so-and-so, who's joining us today for Mincha. And he was able to daven Mincha standing up, not even sitting down. He had a big smile on his face, and he would have been written off. He would have been said, this person doesn't have any high expectation of living, and therefore it doesn't pay to do certain medical procedures to him. So doctors need to have a certain amount of humility, and Rabbanim as well need to have a certain amount of understanding that we don't know everything in medicine. And my philosophy is, whenever you're in doubt, if things are not clear-cut, then we err on the side of pikuach nefashos, safek pikuach nefashos. We try to do everything. But the philosophy of saying we're going to do everything no matter what is, again, halachically incorrect. One becomes a chovel. The Gemara says that it's also to do certain things to a person who's in a certain state, whether they're a goses, whether they're in the throes of death, whether they're in a situation where you're actually just hurting them, you're just damaging them by doing procedures on them that are medically not going to be successful. If a procedure is not going to be medically successful, then there's absolutely never an indication to do it. The medical prognosis and diagnosis is a factor, obviously, in the halachic decision. And that's why it's so critical that an appropriate doctor speak with an appropriate Rav. Sometimes the doctors may not have the time to do that or the interest to do that. And that's why it's extremely helpful if there's a family member who's knowledgeable in medicine, as a physician themselves, or another healthcare practitioner, that can be that accurate conduit to the Rav to provide accurate information so the Rav can paskin correctly. There are a number of major medical issues that come up in terms of whether you need to provide intravenous antibiotics, whether you need to provide oxygen, whether you need to provide various sorts of chemotherapy. These are most of the time areas that are gray in halacha, and that the family's wishes, i.e. the patient's wishes or the healthcare proxy's wishes, usually are in accord with halacha, can be done if it's l'chumra, they want to do everything. And often, if the family and the person decide that they don't wish to, in many of these situations when the prognosis is very poor, halacha allows them not to do something. When you get down to the more basic food, nutrition, water, oxygen, so then halacha is a little bit stricter in general, but even there may be situations where, again, different poskim under different situations may allow a respirator not to be continued, may allow for the oxygen to be decreased to room air, may allow for various tube feedings even to be stopped. None of these answers are simple. None of these answers are absolute. And because Yankel Shmerel did it this way and Chanala had it done this way does not mean that that's the halacha for your individual case. And that's why it's so important to establish that relationship with the Rav. Finally, the last thing that I want to say is that it's extremely important to prevent machlokas. There are, unfortunately, situations around the end of life that can be very, very difficult emotionally. And if it's not planned out beforehand how these issues are going to be dealt with, you can break apart a family. And it's the worst thing in the world when the death of a loved parent, the death of a beloved grandparent causes, Rahman al-Islan, kitata, fighting, and permanent machlokas in a family. And that's why these issues should be decided while the patient is healthy. And the patient needs to sometimes tell the family, I want all of these decisions to be made by so-and-so who is the healthcare proxy. And his decisions are to be respected by all the children, all the grandchildren, all the brothers and siblings, whoever it may be involved, without question. Because that's what I want. And if it's done properly, if it's done prior to the illness being so overwhelming that the person is not capable of making those decisions, you can prevent a tremendous amount of agmas nefesh. And then we can be zolcha to the bracha that Yaakov Avinu requested, that holy come, that death come with illness, to allow the patient to properly lead this world with the proper end of life. That's what we all would like in peace. Ad Me'av Yasser Shalom.